with the Okay, thank you very much. Well, good afternoon, everyone, and welcome to the third public stakeholder meeting convened by the House Bill 413 Interagency Work Group. My name is Kathleen Borain, and I serve as the Maryland Insurance Commissioner. I really like to thank everybody for their flexibility in rescheduling today's meeting. A primary, if not the primary purpose of this meeting is to discuss the results of the modeling that's been conducted on the economic impacts of some of the test scenarios related to the reinsurance fund and other market reform strategies. And frankly, some of those results just took a little bit longer than anticipated. And we wanted to assure that we were able to publish materials well in advance of today's discussion so that today's discussion could be a very useful one. And I hope that that has proven to be the case and folks have been able to have access to those. They've been up for a week now. So for background, and let me just ask everybody who to go on mute because we are getting some background noise. So. All right, thank you. So for background, and as a reminder for those of you who are joining us again, in 2022, the Maryland General Assembly passed House Bill 413, which extended the 1% health insurance provider assessment that is part of the funding for the reinsurance program through 2028. That was then the anticipated, but now verified, end of the 1332 waiver extension period. House Bill 413 also required the MIA, in consultation with the Maryland Health Benefit Exchange and the Maryland Health Care Commission, to report to the governor and the General Assembly on the impact of the state reinsurance program by December 1st of this year. In preparing this report, the MIA is required to consider several factors: the necessary level of funding for the program, sources of funding for the program, market reforms needed to provide affordable health coverage in the individual market, and design of the program and program parameters in light of existing market reforms at the state and federal level. To complete this report, the MIA formed an interagency work group with representatives from MHBE, MHCC, and the Maryland Department of Health. Representatives of these agencies have been meeting regularly since February to work on the development of the report. And a critical part of that process is securing stakeholder input, both in these public meetings and by inviting written comments on the topics being discussed at each of these meetings. So to that end, during our first meeting on May 11th, we discussed Maryland's reinsurance program size, design, and parameters. In our second meeting on May 25th, we focused on market reforms beyond reinsurance that have been implemented or considered in Maryland and other states, and the impacts those have had or would have on our market. Stakeholder feedback provided during those first two meetings was vital in informing the actuarial modeling that will be presented and discussed today. After today's meeting, the working group will be preparing a draft of the report, which we will circulate for public comment, including another virtual stakeholder meeting. The extent and nature of those comments will then guide our process from that point. But we will continue to have a very open, collaborative, transparent process as we finalize the report and make sure that it gets to the governor and to the General Assembly by the due date of December 1st. So as attendees who have joined us previously are familiar, as we make our way through the agenda, stakeholders are invited to raise their hands with questions and to provide feedback when they're asked to do so. Any attendees wishing to take part in the conversation that did not sign up in advance, please just indicate in the chat that you would like to speak up, and to the extent that time and technology permit, we will ensure that you have the ability to do so. You'll also see that at the end of our agenda, we did leave some additional time for additional public comment for attendees to provide any other broader comments that they wish to convey. To help ensure excellent sound quality through today's meeting, we ask that you please stay on mute unless you're speaking. And if you have any technical difficulties, please reach out to Craig I via direct message or email. His email is in the chat. Now, before we jump into our agenda, I'd just like to take a moment to introduce the members of the HB 413 working group, starting with the representatives from the Maryland Insurance Administration. So first, let me introduce our Chief Actuary, Brad Boban, our Senior Actuary, Adam Zimmerman, the MIA's Director of Legislative and Regulatory Policy, Jamie Sexton, and the MIA's Chief of Communications and Public Engagement, Craig I. If there's anybody that I missed from the MIA, please just let me know, speak up. We are also joined by representatives from our partners in the work group. So from the Maryland Health Benefit Exchange, I'll just ask to now introduce themselves. Our Executive Director, I know Michelle Eberly is here.
Hi, thank you, Kathleen. Yes, Michelle Eberly, Executive Director, MHBE. Johanna Fabia Marks, who's our Policy Director, has been very much engaged, is on a well-deserved vacation, so she's not with us today. And Amelia Marcus is on, and I'm not sure if Becca Lane is on or not, but that's our team that's been participating. Thank you.
Thank you very much, Michelle. And from the Maryland Healthcare Commission, let me give you an opportunity to say hello and introduce members of the team who are here today.
Hello, my name is Kenneth Stratman. Ben is not here today. Also, we have Tracy DeShields as well on the line. Thank you.
Thank you. And there are several groups from within the Maryland Department of Health who I'll just give the opportunity to introduce themselves. Amelia. Well, the Maryland Department of Health has been really instrumental in all of this work, both Medicaid unit and our health financing unit. So I'm not sure whether people are having a little bit difficulty getting back online today, but we'll move forward. So if there are any work group members who have not had the opportunity to introduce themselves, please chime in. So with that, we will move forward with today's agenda, which is to discuss the actuarial modeling that has been developed over the past 2 months and frankly, how to fund the various scenarios that we've been discussing. So we're going to start with a presentation from MIA's Chief Actuary, Brad Boban, on reinsurance program funding mechanisms, followed by a summary of the actuarial modeling results, and then what I expect to be a very robust discussion on appropriate funding priorities, levels, and sources. So with that, let me turn it over to you, Brad.
Thank you very much, Commissioner. Craig, if you could put that first slide presentation up, please. Thanks. If you could please go to the next slide. First of all, I just want to level set that this slide deck is a summary of funding mechanisms that are being used by other states for their 1332 waiver and for premium subsidies outside of the 1332 waiver. In general, though, CMS doesn't have any restrictions on how states can fund things. And this is an area where, the states are allowed to innovate. So, we have gotten other stakeholder comments about other ways to raise funding, such as tobacco tax or alcohol tax or lottery funds. And, any of those would be a possibility, but they're not included in this because no other states are pursuing those funding options. So just with that level setting, I'm going to walk through what the other states that have 1332 waivers are doing. The predominant way to fund these waivers are through health insurance premium assessments, analogous to what we are doing in Maryland. There are 8 states that are funding their waiver either partially or fully through the health insurance premium assessments. 2 states are funding through a state's premium tax, Alaska and North Dakota. Technically, North Dakota has a health insurance premium assessment just like we do, but they make theirs 100% deductible from the general premium tax. So it ends up just offsetting premium tax. So they're being included with Alaska in this presentation. 3 states are funding their program through general funds: Wisconsin, Georgia, and Minnesota. And then 2 states have individual mandates, like the federal individual mandate that was repealed. And they're funding their programs partially from the penalties associated with those individual mandates for taxpayers that do not qualify for an exemption and do not purchase insurance. And then Colorado is using a multi-funding approach. They're using a health insurance premium assessment. They're using a 2-year hospital assessment. They're using a portion of the state's premium tax revenue, and they're using general funds. So that's the high level picture. Craig, if you could go to the next slide, please. So as far as the state assessments, this is the magnitude of what the different states are using. The highest assessment is in Pennsylvania at 3%. A note on that one is that it's only for issuers participating in the market, in the penny market in Pennsylvania. And then, you know, you can go down the chart, you can see that on a percentage basis, Maryland's 1% is the lowest percentage out of any of these state assessments. But then I've got New Hampshire and Maine at the bottom. Neither of them do it on a percent of premium basis. New Hampshire does it as 0.6% of the previous year's second lowest cost silver plan. If we did it like that, it would come out to slightly less than the 1% that we're currently charging. And Maine charges a PMPM basis instead of a percentage basis. And that PMPM is also less than the current Maryland assessment. And then the Colorado assessment is to be determined. This is part of their recently approved waiver amendment. And they are in the process of setting it, but as of now that they have not set a rate. Next slide, please, Craig. More about the Colorado waiver. So you know, as I had said on the first slide, you know, they're using multi-funding mechanisms. They've got the premium assessment, which is intended to be ongoing, and that rate still needs to be set. Then they've also got a temporary 2-year assessment on hospitals and other medical providers. They have also not yet published that rate. Then they also have, quote unquote, the ability to divert state premium taxes into the reinsurance fund. But whether or not that diversion is going to actually happen and what amount that is going to be has not been determined. And finally, as far as general funds go, that is earmarked only for the administration portion of the program, not for paying actual reinsurance claims or paying any of the Colorado subsidy. And so, you know, that's how their multi-pronged approach is set up to work. And then in other new changes to waivers, Oregon has had a 2% assessment for a while, but they have expanded it to include self-insured public employees. So the state of Oregon and local county governments in Oregon, and you know, they have defined premium equivalents in the law as claims plus admin costs. And so now all of these public employees are going to be helping to fund the program. And that is a unique thing that only Oregon has done so far. They've not actually started collecting that. That's going to start next year. Next slide, please, Craig. So as far as how much the assessment brings in, currently at the 1% level that it is approved under current law, we're projected to bring in a total of $752 million over the 5-year waiver extension. So that's an average of just slightly over $150 million a year. And then on this slide, these values represent increasing up to the levels that other states have. Minnesota is at the 1.2, Delaware is at the 2.75 at the bottom. And so, this is the range of percentages that the other states are using. I didn't go up to the 3% for Pennsylvania. But this shows, that if we scaled up the magnitude of the increase, this is the kind of annual funding that would be generated from scaling up. Next slide, please, Craig. So as far as the premium taxes go, as I said, Alaska is funded explicitly straight from the state premium tax and has been since they were first approved. North Dakota has a health premium assessment, but they allow carriers to deduct dollar for dollar 100% of that assessment from their premium tax bill. So it's effectively just redirecting the premium tax dollars. And then Colorado is partially funded by premium taxes. So, there is the greater question of whether or not a portion of the state's premium tax could or should be earmarked towards the 1332 waiver. I think there's the question of whether it is appropriate for the non-health lines of business to be paying for these healthcare initiatives. But these are the considerations if we were to consider, taking an approach like one of these states. Next slide, please, Craig. General funds. In general, the drawback of general funds from talking to states where general funds are used are that, state budget uncertainty can cause the financial projections to be more uncertain. And that budget shortfalls in state revenue are correlated with recessions, which are also, when these programs are most needed, as there are job losses and increased number of people in these programs. And so, without having some kind of dedicated, if it were to come from the general funds, without having some kind of dedicated amount and just having it be up to annual, allocation, there's this kind of risk there. And so, Colorado, like I said, are approaching it where, it's the administrative funds only and not the main bulk of the program that are being funded by the general funds. Next slide, please. As far as the individual mandate goes, the tax data from when the individual mandate was in effect in Maryland showed a very regressive pattern of payers of this mandate penalty, with a large number of relatively low income households who, are under 400% FPL and would have been eligible for a premium tax credit if they had purchased, are who are paying the bulk of the penalties. And as far as the effectiveness of the individual mandate, in retrospect, looking back at the effect that happened when the individual mandate was removed, and the difference between states that have kept the mandate and not, overall, the mandate did not prove to be very effective at incentivizing people to enter the market. And that's mainly a function of, the magnitude of the mandate being much smaller than the magnitude of premiums for people paying the unsubsidized price. Next slide, please, Craig. And then, as far as a hospital assessment and applying that to the Maryland model, something that other states do not have to take into consideration that we do need to take consideration is the total cost of care model, and the requirement to keep the growth of our costs below the national level. And so before and if we wanted to pursue any kind of assessment, temporary or not, in the vein that Colorado is doing, you know, that would be a major consideration that Colorado does not have to deal with. Next slide, please, Craig. And then finally, we wanted to touch upon a possible source of funding outside of a 1332 waiver for the premium tax subsidies and cost sharing reduction subsidies type of programs. And that would be a Medicaid 1115 waiver. So the Medicaid 1115 waiver, you know, the state already has a Medicaid 1115 waiver. 1115 waiver can do a lot of modifications to Medicaid, but in this context, in specific, this type of waiver funding is, you know, based on a hypothetical where the waiver proposes the hypothetical of the state expanding Medicaid to a certain threshold, like 200%. And then it gives a counter to the hypothetical and shows that if instead we create a state premium tax subsidy and a cost sharing reduction subsidy and keep those members in the individual risk pool, that we can save the federal government money versus the hypothetical where we expanded Medicaid. And, you know, in this case, you know, the 1115 has an actuarial analysis done. And if it can be demonstrated that the state saves money for the feds, then, you know, the feds can give you money to fund your premium tax subsidies and your cost sharing reduction subsidies. And so these types of 1115 waivers are being pursued by the New England states that have state specific premium tax subsidies and cost sharing reduction subsidies. And so Connecticut hasn't approved one of these. Massachusetts, Vermont, I believe. Next slide, please, Craig. Yes, so the states that have it are listed at the top. The one thing that to be aware of is that no state has simultaneously gotten both a 1332 waiver and this type of 1115 waiver approved. Each waiver would be independently evaluated. There are separate processes. These will be submitted to separate federal agencies. They would each be evaluated independently. But the actuarial analyses would need to take each other into account. And there would need to be a stacking order. And you know, right now it's unclear whether a state can get savings for the specific population targeted from both waivers. You know, the 1115 waiver, the savings are based on, you know, saving the money, the Fed's money versus a hypothetical where that person would have been covered in Medicaid. And a 1332 waiver, the pass-throughs are based on saving the federal government in a hypothetical where the feds would be paying higher APTC levels with no reinsurance going on. And you know, technically one person can't generate both of the savings at once, but it's not clear because no state has both of these waivers, whether or how the federal government would be taking that kind of overlap into account. So it's possible that if the state did try to pursue funds through an 1115 waiver, that it could lead to a reduction in 1332 pass-throughs. Even if it did lead to a reduction in pass-throughs, we could still be better off. The net result might be a gain in total funding if there's more per person savings on the Medicaid side than the pass-through side. But there also might not be a reduction. Like I said, this is an unknown, untested scenario right here. But you know, it is a potential that you know could be pursued. And I think, Craig, that's the last slide. Is there one more? Yeah. So at this point, my intention was to hold discussion about which of these funding mechanisms is preferred till after we go through the next presentation, talking about all the costs. But if anybody has any questions about anything I just presented, I would say now I can, answer any clarifying questions, but let's save the discussion for after we go through the other presentation.
Collison?
Thank you, Commissioner, and thank you, Brad. I'm not sure that I can, that this question is answerable at this point. One of the things that so I'll make a comment and then I have a question. In terms of raising the premium assessments, I worry, when I have to defend this bill on the floor, the question always goes back to who's actually paying that amount. And it's literally not the carriers. It is the people who are paying the premiums. So I think, if we were to look at raising premiums, I think, that's going to be a tough battle to fight, particularly now when folks are projecting not necessarily doom and gloom, but at least some level of economic challenges over the next couple of years. So that's one thing. The other thing on the 1115 option, do you think that there would be a relationship, Brad, between if we were to expand Medicaid, just expand it in general, could we see a decrease in the need for the insurance program because we are covering more folks who may be using those reinsurance funds now because they don't get the preventive care that they could potentially that could have if they were covered by Medicaid? So I don't know if it's sort of esoteric, I think, but I just wanted to put it out there.
Yeah, I mean, as far as the Medicaid question, in the next presentation, we go through the cost to the state of what would happen if we expanded Medicaid. And the long story short is it would be very, very expensive to the state, and we would lose a lot of federal funding. Whether or not it would help improve the overall health is not within the scope of what we studied, but we did show, a very large cost to the state, and that's going to go through in the next presentation. But to be clear, this Medicaid 1115 waiver is to not actually expand Medicaid.
Right.
The Medicaid expansion is the hypothetical upon which federal savings are measured, and that's the source of the funding in this 1115.
Right. I'm not sure that I understand all the details, but I did understand that it was not actually expanding services. So just kind of, adjusting the funding formulas, basically. So, okay, thank you. Well, I'm sure I'll have more questions as we go along.
All right. I don't see any other hands raised, Craig. So if you could tee up the next slide deck, please. All right. If you could scroll ahead to the next slide, please, Craig. All right, so there are a lot of numbers in this presentation to go through. I'm going to try to keep it as high level as possible. We're going through all the numbers we need. As a high level thing, a lot of modeling was done in a very short period of time. There have been some simplifying assumptions made. All of this modeling, should be thought of as a good first estimate. But if we're going to pursue any of these initiatives, there are going to be additional iterations of modeling that they get more sophisticated and remove the simplifying assumptions to get things done quickly and replace them with more realistic assumptions to make better projections. So just want to level set everybody there about, all of these numbers. I can answer questions to the best of my ability about what assumptions and what simplifying things we've made here. But, like I said, this is a balance of getting meaningful results in a relatively short amount of time. So with that being said, Craig, if you can please go to the next slide. So this is a summary of the current waiver. And I've pulled high-level numbers from a much more detailed projection. At the top, that first row, everything in this table is in millions. That first row shows the reinsurance cost to the state. In 2019, it was $353 million. It increased to $485 million in 2022. That is an actual final number, and in 2023 is a projection, that $544 million. But over the entire 5 years, it's $2.25 billion in reinsurance. The next row is the federal pass-throughs. All of these numbers are final. And so, over the 5-year period, we got $2.1 billion in federal pass-throughs for our waiver. And then, if you scroll down to the next section, you can see the state assessment. That first year, it was $327 million because we were charging 2.75%. And then it dropped to 1% in 2020 through 2023. And so that's why the state assessment dropped down to 119 million, then started increasing again. The row below that shows the state share of reinsurance. As a reminder, in the first 3 years, we paid nothing towards reinsurance because the feds covered everything. 2022 is the first year that the state has had to chip in towards reinsurance. There's an estimated $66 million. And then 2023 as well. But over the 5-year waiver, the state is expected to pay $137 million of the reinsurance cost. So, overall, the feds are covering, 95% of the total costs. And then you can see this other state outflows line. And that is from the budget bill that passed in 2020. That $100 million that came out in 2021, that went to Medicaid. In 2022, that was originally supposed to be 100 million, but then that got cut to 50 million. There are outflows to a couple different programs, all bundled into here. Overall, more outflows went to other programs that weren't reinsurance than reinsurance in this first waiver. And then if you skip down to the end of year state balance, that shows that we have ended our first waiver period, or we're projected to end our first waiver period with $487 million in state balance. And that's driven by those first 3 years where we didn't have to pay anything. As I said, that 544 is still an estimate for this year. It's an estimate not looking at any data from this year. You can't really estimate reinsurance mid-year by looking at the data, because reinsurance applies to a claimant's entire year's worth of claims. So this projection is based on looking at 2022 claims, projecting it forward for trend, projecting it forward for expected changes in morbidity, and projecting it forward in this case for the change in attachment point. Because in 2023, we lowered the attachment point from 20,000, where it had been for the first 4 years, to 18,500. And so that is all built into that $544 million projection. There's not a huge amount of uncertainty there. It might come in closer to 500 million. It might come in closer to 600 million, but that's the reasonable range there. And so, we're definitely going to end with a state balance. It might be lower than that if that 544, if it comes in a little bit higher than that. But, this is pretty certain at this point. And then, Craig, if you could go to the next slide. So this is the waiver extension. And this is the scenario where we assume ARPA expires. So this is consistent with what's in the approved waiver extension. with one exception. The approved waiver extension assumed we were going to be at a $19,500 attachment point in 2024, but that's been finalized at $20,000. So this reflects that updated attachment point. Just like the waiver extension, this assumes the attachment point is going to be raised by $1,000 a year. So it's starting at $20,000 in 2024, and it's going to be up to $24,000 by 2028. And that is to help control that rate of reinsurance growth. And so on the previous slide, the average rate of growth was a double-digit rate of growth, because by leaving the attachment point the same, we were experiencing deductible leveraging, and it was causing the reinsurance cost to increase at a faster pace than trend. And so this $1,000 increase helps offset that. And so now you've got the reinsurance cost increasing at a low single-digit level instead of a double-digit level. Then when you look at federal pass-throughs, you can see that in the first 2 years, the federal pass-throughs are pretty high. And then in 2026, they fall significantly by 17%. That is the effect of ARPA expiring. ARPA inflates all of our pass-throughs because our pass-throughs are based on the percentage of you know, that we're saving the feds on on their premium tax subsidies. And so when their premium tax subsidies are at a higher level, the same percentage of a higher level of subsidies is a bigger number. So our pass-throughs will get deflated when ARPA expires. And you can see then down below where it compares the state assessment versus the state reinsurance cost, that in those first 2 years, in 2024 and 2025, we're bringing in enough in state assessment to cover our expected share of reinsurance. We've still got $35 million in other outflows. $20 million of that is the young adult premium subsidy. The other $15 million is the health equity fund. So with those costs, we're pretty much close to breaking even those 2 years. But then in 2026, the state share of reinsurance jumps to $203 million from $102 million. And so that's the effect of those pass-throughs that dropping. And so from 2026 to 2028, we're no longer bringing in enough on a year-to-year basis to cover our share of reinsurance. But we have all the funds left over from that first waiver and you know, from the first couple of years of this one. So we just start to draw that down. So, you know, we end this next projection at 336 million. So you know, it's at a lower level than the funding is at now, but this shows that even if ARPA expires, you know, the current 1% with the excess that we built up, it is projected to be sufficient. Next slide, please, Craig. So this is the more optimistic scenario where the feds extend ARPA in 2026. So the big difference there is in that second row where the federal pass-throughs don't drop. And in this scenario, the 1% state assessment is projected to be sufficient to cover the state portion in all years, more than sufficient. So you see the state balance down at the bottom start to grow again. So in this ARPA extend scenario, we're projected to grow our state balance to $678 million by the end of this waiver extension. And so, you know, that shows how important that ARPA extension is. That's a $300 million difference between those two scenarios, you know, as far as what the state costs are going to be. Next slide, please, Craig. All right, so now to talk about the reinsurance parameters and the history. So the first waiver had a $20,000 attachment point and 80% coinsurance, $250,000 cap for this first 4 years. In 2023, it was lowered because of the uncertainty, because it looked like ARPA was going to expire and it looked like we were going to have double-digit increases without that. For 2024, we're going back up to $20,000. And then, as I said, the waiver extension anticipated that plus 1,000, and so does the modeling that we just showed you to talk, control that growth rate of growth of those reinsurance costs. And then, as a benchmark, on a percentage of claims basis, that plan 25 attachment point of 21,000 with an 80% coinsurance and a $250,000 cap is expected to cover a little over a third of claims in the individual market, 33.6% of claims. So with that, if you could go to the next slide, please, Craig. One of the modeling exercises we asked Lewis Nellis to do was to see how we could change the reinsurance parameters in a revenue neutral way. And, with the goals of both raising our attachment point, because we are the lowest attachment point in the country, and or lowering our coinsurance because we're the highest coinsurance in the country. So they came up with these 4 options. They used the cap as the variable they changed. Right now our cap of 250,000 is, right about average nationwide. But other states go up to 1 million. And so, that wasn't in the realm of what they modeled. So, that first row, they modeled that if we wanted to lower the coinsurance from 80% to 70%, so that puts, more skin in the game for the carriers. They have to cover 30% of claims for those members instead of the 20%. But you would have to raise the cap all the way to $1 million to actually do that. And as far as raising the attachment point goes in a revenue neutral way, if we kept our 80% coinsurance and raised the cap to $500,000, you could raise the attachment point to $26,000. If you raise that cap to $1 million, it gives you room to raise the attachment point to $28,000. And finally, if you raise the coinsurance, which is the wrong direction in my opinion, but for the sake of modeling, if you raise the coinsurance to 90%, raise the cap to $1 million, you could raise the attachment point to $35,000. $35,000 would still put us on the bottom end of the range of attachment points being used by other states. So, in my mind, this modeling exercise shows that there's not very much room to modify our program in a revenue neutral way. Maybe number 2 might be a slightly more attractive option than our current, $21,250,000 cap, but the difference is relatively marginal. So given these results, then we moved on to modeling on the next slide. And so this set of modeling is not revenue neutral. And so this says, what happens if we raise the attachment point? And it's been modeled as, what percent of claims are we expected to hit? That it was 33.6% of claims under the current attachment point. And then what's the estimated premium impact to the pool on average? The premium impact would vary a lot by carrier and by plan, but these are high level estimates of that. So, going from 21,000 to 25,000 without making any adjustments to anything else, that's going to lower it only from 33.6 to 30.5. That's about a 4% premium impact. And then you go from 30 to 40 to 50,000, you can see, you're getting an ever shrinking percent of claims. 50,000, it's under 20% of claim, and a pretty significant premium impact. And so these were modeled as, kind of a range. And I would say, you should be able to interpolate between these numbers. So if you want to estimate what 35,000 would be, split the difference between 30 and 40,000, and it's going to be a decent, estimate. And the same sort of exercise was done with lowering coinsurances. In this one, they kept the cap at $1 million. But this same exercise could be done with lower caps. But for lowering the coinsurance to 70%, it would lower the percent of claims the state covers to about 29% with a plus 7% premium impact. And going down to 60%, would be about a plus 14% impact. So, this is a range of things. Like I said, this is not the limit. Other states certainly have higher attachment points than shown here and lower coinsurances. But, wanted to give some set of numbers. We went and modeled 2 scenarios where we raised the attachment point in a relatively gradual manner. So if you could go to the next slide, please, Craig. So this scenario says what would happen if we raise the attachment point by $2,500 a year instead of by $1,000 a year. And so, in this case, you can see that top row, the reinsurance cost, is virtually flat. The increasing 2.5% more than offsets trend in this case and keeps that top line almost flat. The federal pass-throughs also get lowered though, because we are not having as big or an impactful program. And so, the state assessment, that does not change, but the state share of reinsurance does change. And in this case, it is lower. And so, the ending state balance in this scenario would be $446 million. And so that was versus $376 million in the scenario where we just raised it by $1,000 a year. So over that 5-year period, that increasing the pace of changing the attachment point, saves the state about $70 million. But then there's also going to be a bigger premium impact because of that. That's bringing, this is going to bring this up to a $31,000 attachment point at the end of that 4-year period. So that's the trade-off there in this scenario. And then if you could go to the next slide, please, Craig. This is a similar exercise where instead of raising it by $2,500 a year, we raise the attachment point by $5,000 a year. So in this one, that rate of increase more than offsets all of the deductible leveraging claims trend and leads to the reinsurance program shrinking over time on an absolute basis. And so that first row shows those reinsurance costs on an absolute dollar shrinking. And then once again, it also lowers federal pass-throughs, but the pass-throughs don't fall by as much as the reinsurance costs do. So this leads to lower state cost again versus the last scenario. And so this scenario leaves us with an ending balance of $582 million. And so, their modeling is set up to do these kinds of projections relatively easily. So we could certainly do other scenarios of this nature. Like I said, these were chosen as some illustrations of what could happen if we started changing the attachment points. All right, Craig, I think next slide, please. All right, so this is going to move on to the impact of the ARPA subsidy expiration. So next slide, please. So this slide shows what happens to the ARPA premium, to the subsidized premium, when the federal subsidies go from the current enhanced ARPA level back to their original ACA level. This example shows the premiums for somebody that selects the benchmark plan. The benchmark plan is the second lowest cost silver plan. In their zip code. This is an age 64-year-old, which is the highest rate. That example was chosen to illustrate the cliff. But you know, it would impact other ages to a lesser extent, but this is an example, like I said. But you can see, you know, at the low incomes, you know, that 150% and lower is right now paying 0 under ARPA, and they go back to paying $65 under original ACA. And you can see, you know, as you go up in income, you know, it's extremely high percentage increases, even on a dollar basis. You know, these people are going to be seeing, you know, quite frankly, massive year-over-year increases if ARPA is allowed to expire. So this situation was, you know, what gave us the fear that we were going to have a big loss of enrollment and a worsening of the health status of you know, the population. You know, as people that were enhanced, you know, enticed into the market because of the enhanced subsidies fled again when they saw these increases. So if you could go to the next slide, please, Craig. So I apologize if this is a little hard to read. And yeah, I just saw a comment in the chat. These slides have been updated since what we released last week. There were some placeholder slides last week for modeling that had not been completed. And some slides like this one in completing the placeholder slides were revised a little bit. So I think the version that you saw last week has 147 million total versus the 149 million here. We will be publishing a final version of these slides as well as updated Excel versions with all the updated numbers since last week. But just wanted to make it clear that you know, there are differences between what was sent out last week. But this quantifies that impact of losing those ARPA subsidies by age and FPL. So this top table, you know, it's $149.3 million total, but you can see in the age and FPL buckets. If you go down the right-hand side, those bold numbers, those are the subtotals by FPL. So you can see dollar-wise, those very lowest FPLs are not a lot of dollars for these ARPA subsidies. You know, but then, you know, as you go up, it says mid-income, the 150 to 250, where you know, really large dollar amounts of these federal ARPA subsidies are focused. And then if you go along the bottom, that's the subtotal by age. And you know, you can see that age 55 to 64 gets a lot of these enhanced ARPA subsidies, 57.9 million total. And specifically that cell, that 400% plus cell with the 55 to 64, that's part of why I chose a 64-year-old as an illustration. You know, part of what ARPA has done is remove the cap on subsidies. And so now anybody of any income can get subsidies, but you only can get those subsidies if the unsubsidized premium would cost you more than 8.5% of your income. And the only group for which that is really true are these older 55-year-old plus. So, you know, removing that cliff is almost entirely benefiting this older population. You know, you can see, you know, a few $100,000 in the lower ages, but the bulk of the money is in these older ages. So like I said, this shows the distribution of where all these ARPA subsidies are going. It's $149 million in 2026 projection. It's projected to go to 157 million in 2027 and 166 million in 2028. If the state were to offset this lost subsidy, the reinsurance projections would improve versus what we showed you previously. And that's because the expected enrollment losses were not occurred. And so when we went through that slide where ARPA expires, there was a big drop in pass-throughs, and that was driven by two factors. One factor was that on a per person basis, there was less pass-throughs because the federal subsidy level was at a lower level. And that's unavoidable. We can't get around that. But the second reason for the drop in pass-throughs was fewer people getting subsidies. And that's what we could get around if we replaced the subsidies with our own. And so this next modeling shows what that would do. And so if you could go to the next slide, please, Craig. So this shows, like I said, that pass-through number in 2026, instead of dropping 17%, in this scenario, it would only be expected to drop 10%. And so that leaves the state paying less per year on reinsurance. So for 2026, instead of having paid $203 million in reinsurance, we've only got to pay $174 million now. But now I have this other state outflows here. So we would have to pay that $149 million in state subsidy to replace ARPA. So, the net picture is, our reinsurance projection gets better. But, we would have all this new outflows for the subsidies. Overall, this leaves us with a minus $48 million position at the end of this period, which says that the current 1% with the current, overflow from the first subsidy could probably just barely do this. I mean, we could certainly tweak, that $50 million shortfall could be covered by going from 1 to 1.1%, or it could be covered by not quite replacing the federal subsidy. Instead of bringing people all the way down to 0, bringing them down to 1% of their income, or instead of making higher income people pay 8.5%, making them pay 9 or 9.5. But it's basically, we could barely just cover it, but then that leaves us with nothing at the end of this next waiver period. And then in the situation of what would happen in 2029, where both reinsurance and the state subsidy would go away. So, if we were really going to replace this state subsidy, we would be wanting to look longer into the future and do a more robust projection. But this just wanted to illustrate, how there would be that positive impact to the reinsurance program itself, and that would help free up some funds that would, be able to be used for this purpose. Next slide, please, Craig. All right, so this next section studies the cost of funding subsidy programs for undocumented immigrants. Next slide, please, Craig. All right, so this basis of all of these modeling is giving this population the exact same subsidy as the current subsidy eligible population for a given FPL. So in the ARPA scenario, it's going to be higher, and it's lower in the ARPA expire scenario. So that's the opposite of reinsurance. But because if the enhanced ARPA subsidies stay and the state's going to match them, it's going to cost the state more. For this set of modeling, the uptake assumption is extremely important to the overall cost, and we've shown a wide range of uptake assumptions because there's a very big uncertainty here. And so, on the low end, we've got 3 scenarios that we're showing: low, mid, and high. On the low end, we've got 8% of those who are eligible enrolling in a QHP. On the high end, 51%. In the middle, 30%. Those percentages are not fixed by age and income. They vary within the age and income, but they average to these numbers. As far as number of people that goes, this translates to between 7,500 and 55,000 new enrollees into the individual marketplace. As a reminder, the total size right now is about 234,000. So that's a meaningful increase to the size of the individual market. And then, we have been consistent with assumptions being used by Hilltop on the Medicaid modeling for the subset of population that has incomes that would qualify them for Medicaid. but we have a lower uptake assumption here than Hilltop is using for Medicaid. And that's just based on the fact that, you know, that there are less barriers to being enrolled in Medicaid, and that, you know, ultimately, you know, even if we get the premiums down to zero in a QHP, we would expect a higher percentage to be enrolled if they were covered via Medicaid versus covered via a QHP. Next slide, please, Craig. All right, so this is one of those slides that's been updated since last week. So this is quantifying the cost to cover the not Medicaid eligible subset of this population. So this is adults over 138% FPL. The top row divides the cost into three broad categories. The slide that was sent out last week only has two of these three categories. The first category on the left is the direct cost of the premium subsidy itself. And we've got 6 numbers here. The left-hand side is no ARPA. ARPA doesn't get extended. The right-hand side is ARPA gets extended. And then we got the low, the midpoint, and the high. So in the low uptake scenario, you know, you got $14.9 million of direct premium subsidy costs, going all the way up to, in the high uptake scenario, when ARPA gets extended, you've got 142 million in direct premium costs. But then that's not the only cost. The second section to the right shows the estimated impact on the reinsurance program. So unlike people that are in the reinsurance program now, these members will not generate any pass-throughs because there are no federal subsidy dollars being spent on them. And so there are no pass-throughs available, but they would be part of the individual market QHP pool, and they would be eligible for reinsurance. And so, you know, this takes into account how much extra reinsurance costs will be added. And then the third section on the right that was not there last week, but we've added, is the cost for giving CSR subsidies, cost sharing reduction subsidies, equal to the federal subsidies. Because for these low income populations, you know, for those under 200% FPL in particular, you know, a silver plan gets cost share reduction subsidies to bring it up to either to an 87 or a 94% level. And you know, if the premium subsidy were going to be effective, it would need to be paired with a cost sharing subsidy, or else it really wouldn't make sense to get people a cheap silver plan without the cost sharing reduction, because without the cost sharing reduction, you know, a silver plan has a $3,000 or a $4,000 deductible, and for people under 150% FPL, that doesn't make sense. So we modeled the cost of giving the same CSRs as on the federal side. And so the sum total of those three are now on the bottom left chart on this slide. And so on the low uptake scenario, you've got a cost of $27 million total if ARPA doesn't get extended, and 41 million if it does. And then in the high scenario, it's a range of 158 million if ARPA does not get extended, to 229 million if it does. And then to the right are the associated enrollments. You know, once again, the enrollment is the big unknown here and is the big risk here. You know, the higher the enrollment, the more the cost is going to be, and that's the big uncertainty. You know, the per person cost for all of these buckets can be estimated relatively precisely. You know, there's uncertainty there, but it's the overall enrollment that has the large uncertainty. Next slide, please. So this shows those same cost estimates for the Medicaid eligible / CHIP eligible populations. So this includes, you know, all of the under 18 undocumented population, and all the adults between 0 and 138% FPL. for all of these, for this population, there are two options that states are pursuing. Some states are covering these people under a Medicaid type program funded solely by the state, and other states are trying to fund them through subsidies and QHPs. And so there is a separate study being done about what it would cost to cover this population under Medicaid. But this is, our estimate of what it would cost to cover them, subsidizing them via, QHPs. And so, the one thing that, is a little bit different on this slide versus the previous slide is that CSR costs are higher relative to the APTC cost, because for this population, everybody in this population is assumed to get that 94% actuarial value plan, the most generous plan. Where on the previous slide, it's a mix of people that don't get any cost share reductions and get lower cost share reductions. But at the end of the day, the cost in the lower right hand corner, once again on the low uptake assumption, $28 to $32 million. On the high uptake assumption, it's $175 to $190 million. And once again, there's not as much of a difference between this ARPA and no ARPA scenario, because this is all that lower income population. And when we looked at where the ARPA subsidy goes for the people getting the ARPA subsidy pop, that 0 to 138 was not getting very much ARPA subsidies. The ARPA subsidies are relatively small for the lowest income and bigger for the higher income. So that's why there is less of a difference on this slide than on the previous slide. And then as far as number of enrollees go, once again, we've got 3,500 on the low end, 23,000 on the high end. Next slide, please, Craig. So other states who have implemented programs like these have implemented them phased in over time, not all at once. It's typical to prioritize children 0 to 18 first, and seniors age 65 second, and then kind of fill in the gaps and expand upwards from 18 and or downwards from age 65. That's kind of approach helps to address the very large uncertainty over the uptake level. It lets you get some data about what the uptake is going to actually look like in the early cohorts that you let in, and make better projections for the later cohorts, and it controls the pace at which your program expands. Next slide, please, Craig. And so the modeling that has been done, like we did for the APTC ARPA modeling, has been broken down by the age and FPL levels. This slide combines the two populations that we looked at separately just now. That they are in separate file tabs in the Excel version that is released right now. But I've combined them into one to give an overall picture. The first section at the top shows the enrollment numbers. And like I said, all of these are linked to uptake assumptions. In the Excel, you can see the uptake assumption for each particular FPL. But this is linking census data and data about the uninsured population with uptake assumptions for each FPL. And this is the expected number of people that would enter the market in this mid uptake scenario. Then in the second section down here, you can see the per enrollee annual cost. And so, you can see some variation at the young ages. It's only $2,300 a year to cover the subsidies. At the older ages, it's more like $8,000 a year. That's driven by the 3-to-1 age rating, and older premiums being a lot higher. Similarly, at the lower FPLs, it is more expensive per year because we're subsidizing a greater percentage of the total premiums. So for the lowest FPLs, you know, the average is significantly higher than the higher FPLs. Next slide, please, Craig. And then this shows basically the prior two tables multiplied together. And so this shows the total premium subsidy cost of 147 million for this cohort in this mid scenario. And to be clear, all of this is just the premium subsidy part. When we get the final Excel version out there, there will also be the tables for the reinsurance cost component and the cost sharing reduction component and the grand total component. Everything needs to be cleaned up still, but this is the premium subsidy component only. But you know, it shows once again, you know, the subtotals on the bottom are the subtotals by age. The subtotals on the right are the subtotals by FPL. And so, you know, if the state did want to focus on particular subpopulations, this is the data that showed, you know, if that 0 to 18 and 65 plus approach were taken, you know, those two buckets have about $13 million of cost out of the total $147 million of cost. So that greatly limits the magnitude of the subsidy, you know. So this gives, you know, an example, and the final Excel is going to have, you know, all of this detail for the low, midpoint, and high scenarios to give those different sets of projections. Next slide, please, Craig. All right, so now I'm going to move on to the supplemental state subsidies. Next slide. So these subsidies are extra subsidies for people that are already eligible for the federal subsidy. All of the modeling that was done was modeled as a flat PMPM. That's not the way our current young adult subsidy works, but it is easier to model and is not as regressive as the current method. And you know, so that's the approach that was taken with this modeling. The only exception is that when we say flat PMPM, you know, that's except for members who don't need a full subsidy to get to zero. So, you know, especially on the higher ones at $125 PMPM, a lot of people are not getting that full $125. You get enough to bring your premium to zero, and then it gets cut off. And so, you know, that's the only caveat with here, but otherwise, if your premium doesn't get reduced to zero, everybody gets this flat PMPM regardless of income. And then the ARPA scenario is higher mainly because of more enrollees. It's the same cost per enrollee, but there's more people expected to be here in the ARPA scenario. So $40 PMPM on the left is the approximate magnitude of the current young adult subsidy. And that would be around $55 million to extend it to all ages. Going up to 75 PMPM, you know, that increases the cost closer to $100 million. Going up to $100 PMPM, 125 to $133 million, and 125 PMPM, you're up to almost $160 million. These PMPMs were chosen looking at what other states are using and looking at their generosity. Once again, you can interpolate between these values to get an estimate of what it would be like at some level between these. Next slide, please. So this once again gives that detail by FPL and age. This is an example at the $75 level. And so it shows where those dollars would be targeted. This is in the ARPA extend scenario. So everybody below 150% is at zero because the federal subsidies already bring them down to zero, so they can't get any additional state subsidies. In the ARPA doesn't extend scenarios, you'll see numbers in those cells because those people can get state subsidies. But once again, this shows the total cost is $102 million. But if you wanted to focus on particular ages, the current young adult subsidy is for ages 18 through 33 get the full subsidy. So it's approximately those 18 to 25 and 26 to 34s. So you could do those two age bands, increasing it to $75 PMPM. That's going to come out to that, that $24 million. And obviously you can also see the different FPLs and what they qualify for. The current young adult subsidy is cut off at 400% FPL. This goes over 400% FPL because we asked them to model it that everybody who is eligible for federal subsidies is eligible for the state subsidy. And with ARPA extended, that cliff has been removed, so those older people get that federal subsidy. So in this modeling, those older people get that. But that would be a decision point if we were to move forward with some supplemental state subsidy. Other states that are pursuing these supplemental state subsidies are generally only going up to 250% or 300%. Once again, we asked Lewis Nellis to do the full set of subsidy eligible people, but it would definitely make sense to cut it off, at a higher level. But all of the detail should be in that Excel for you to see for the different PMPM level and for the ARPA versus the non-ARPA. Next slide, please. All right. So the state cost sharing subsidies, we started off modeling things with all of the supplemental state CSRs on silver. And that is analogous to what Massachusetts is doing. As we started modeling this, Lewis Nellis pointed out that it would be cheaper to the state to give the enhanced CSR to the 200 to 300% population on gold. Most of these people are already in the gold level because gold has a cheaper premium than silver because of CSR loading. The 2 to 250 population is eligible for very small federal cost share reductions, and most of them would rather have the cheaper gold premium, and the people currently in 250 to 300 are not eligible for anything. So we shifted to modeling the cost for that population to a state CSR that would only be available on gold. And so this is how New Mexico is administrating their program. For people under 200% FPL, you can get the federal subsidy and the supplemental New Mexico CSR subsidy on silver. But for people 200 to 300%, that supplemental New Mexico CSR subsidy is available on gold. So there's certainly the potential for confusion here with needing to direct certain members to certain metal levels to get these reductions, but that's the rationale that was made in doing the modeling this way. And then for this section, we've modeled the impact for existing enrollees only. So there's no assumed uptake assumptions from outside the market. Like I said, that's one of the simplifying assumptions. We did make assumptions about people changing metal levels to obtain these new CSRs, but we didn't project any new people. If we went forward with this, we would probably want to project that. Disentangling how many new people are going to come in because of cost share subsidies versus premium subsidies versus reinsurance is tricky, but like I said, for now, no new enrollment. So next slide, please, Craig. All right, so this slide shows at the very top, we divided into those FPL buckets. So the 0 to 150 range, current federal AV puts them at 94% AV. And then we've quantified the projected annual cost to bring them up to different state targeted AVs. So the first row brings them up just 1% from 94 to 95. That's what Massachusetts does for people between 100 and 150. And that's an annual cost of about 1.3 million. You go down the rows, you know, the third row there shows what New Mexico is doing. They're bringing this population from 94 to 99%. For this population, 100% was modeled because Connecticut and Massachusetts are doing that. But then as you go down the table, you know, the target percents for each of these cohorts is somewhat different, but, you know, we're quantifying the estimated cost to do these different subsidies. And then on the right, you can see that if we were to imitate New Mexico and do what they were doing for each of these cohorts, it would be a $57 million annual cost. If we were to mirror Massachusetts and do what they are doing for each of these, it would be a $54 million total cost, or $73 million total cost. And then obviously, if we were to do our own thing and pick and choose, you know, we could come up with a set of cost sharing reductions, you know, as we felt fit. And I think that's all I have to say on this. Like I said, for those lower two buckets, it says gold base in parentheses, and that's just, you know, that's why the federal AV is starting out at 80%, that these people, you know, are starting on a gold plan and being subsidized up to a better than gold level. Next slide, please. All right, so this is the final section. So this is the impact of removing the under 200% members from the market. So this was chosen, 200% is, you know, the basic health plan level. So you know, this impact on the QHP market is what it would look like if we either expanded Medicaid to 200% or we created a basic health plan. But in both cases, if we remove those people under 200% from the market, we wanted to see what would happen. So next slide, please. So there are three primary types of impacts that would happen if we remove these people from the market. The first impact is the direct loss of APTCs. That right now, you know, the federal APTCs, assuming ARPA gets extended, is $766 million a year. So you know, that is what Maryland residents are getting from the feds to help lower their premiums. And of that, 55% goes to those under 200% FPL. So there is $421 million of federal APTC. And if this population is moved to Medicaid, they're not going to be able to getting that APTC anymore. Then there is a secondary effect for those left behind in the market. And there's two secondary effects. The first is the impact on the federal pass-throughs. So pass-throughs would fall from $500 million with the people in our pool to 198 if those people were removed. Because once again, federal pass-throughs are dollars that we save the feds on federal subsidies. If we remove all of this subsidized population, 55% of the federal subsidies, would remove a lot of potential for savings. And so the reinsurance cost is also going to fall. But at the end of the day, in this scenario, the state has to pay an extra $437 million in reinsurance cost for the program. And then the third impact is the impact on subsidies for those left in the individual market. And so right now, those people that are in right now the APTCs are inflated because of CSR loading. And if the under 200% was removed from the market, the CSR loads would fall from double-digit loads to very small single-digit loads. And that would have an adverse impact on those people that bought plans that were not the benchmark plan. And so if you can go to the next slide, please, Craig. So this shows that reinsurance modeling impact of what would happen if this population were removed. And so, like I said on the previous slide, you know, in 2025, which is what this modeling assumed would be when this population was removed, the reinsurance cost would fall significantly from 579 million to 428 million, but the federal pass-throughs would fall even more. You know, a greater percentage. The reinsurance fall was 26%. The pass-through fall was 58%. And the combination of those leads the state paying a greater share of reinsurance. And so we would have to be paying 230 million out of that $428 million cost. And that would be exceeding our state assessment. And so in this projection, you know, we go from you know, the base scenario where we end up with a $376 million shortfall to this $101 million deficit. Next slide, please, Craig. So this shows how the dynamic with the CSR loading works. So at the top, this shows how the current rates work with the highest CSR load. So you've got the benchmark plan, and then we've got Blue Choice Bronze and Blue Choice Gold as examples of people choosing to buy different plans. We've chosen Blue Choice because they're the dominant carrier, and their Gold and Bronze plans have very high market shares. So in this case, if you're in the benchmark plan, you are expected to pay $113 post-subsidy. And so that APTC of $239 gets backed into. And that is your APTC no matter what plan you choose. So if you take your $239 APTC and you go to Blue Choice Bronze, you can get your plan down to $26. The unsubsidized premium is $265. You have $239 in APTC, you're paying $26. And then Blue Choice Gold is similar. Blue Choice Gold is more expensive than the benchmark plan, but you can still choose to use your subsidy on it. And in that case, it brings your gold plan down to 138. Then the bottom table shows what happens after under 200% has been removed. In this case, the gold and bronze rates have not changed because there is no CSR loading going on in the gold and bronze rates. But the benchmark plan has come down to 287. That's driven by that CSR load being removed, not completely removed, but dropping very, very far. And so in this case, the APTC drops to $174 from the $239 that you're getting right now. If you stay in your benchmark plan, you're still paying $113. Your unsubsidized premium in your benchmark plan and your subsidy fell by the same amount and revenue neutral. But for the very large percentage of people that do not stay in their benchmark plan and choose a different plan, they are going to see a big increase. And that's because, you know, basically, if you look in the far right, the dollar impact, that $66, that's the decline in APTC. And they're going to fill that because they're not in that benchmark plan. And so, you know, people in that bronze plan currently are paying 26 and would start paying 92, and that would be a 250% increase. Similarly, in Blue Choice Gold, you go from paying 138 post subsidy to 203. So, you know, this is the side effect of removing those inflated CSR loaded subsidies. Next slide, please. All right, and finally, this came from the Maryland Department of Health. They gave me their own slide deck that outlines the assumptions and methodology behind these estimates, and we're going to be publishing that as well. But this is the estimated cost of actually covering those people who we remove under 200% in Maryland Medicaid. There's a low range and there's a high range and there's a best estimate at the top. The best estimate at the top is that the annual cost for these people are going to be about $420 million, and it's a 50-50 state share. So it would be $210 million to cover this population under Medicaid. And so, you know, all of these things added together, it's a really big cost to move these people out of the QHP market and into Medicaid. You know, this direct cost plus the loss of federal APTC plus those negative effects on the existing QHP market. So, you know, out of all of the reforms talked about here, I mean, I think this one is the one that definitely has the biggest adverse side effects. But you know, we wanted it to quantify all these numbers and you know, lay this all out. And so with that takes us through all the separate modeling exercises that they did. I know I've just covered tons and tons of numbers and a lot of detail. I say before we open it up to discussion, are there any questions for me? I've heard some chat buzzes, but I've not been reading. So I can answer any technical questions before we open it up to discussion.
So Brad, let me just make one comment, because I think you're exactly right. We want to give those people who have had a chance to absorb this information the opportunity to ask their initial questions about numbers, et cetera. And we want to have whatever meaningful discussion we can have at this point. However, I want to make it very, very clear that we know that this is very dense. We want people to be able to send in their written comments. We are open to having an interim meeting for us to come back and just not have more data and more presentation, but to give people a little bit more time to think through it, read through it, work through their written comments, maybe look at some of the written comments that others are posting, and then have an interim meeting for discussion before the working group completes its initial draft. And I want to stress the word initial draft of a report, which itself will be, you know, it will include recommendations or will include options, but it will, you know, be circulated for discussion before it's finalized. So I want to make it very clear that we're going to be guided by the stakeholders in terms of being able to come back and dig more into this information as we need to do so. But to Brad's point, let me stop and let folks who have particular data questions or methodology questions and have those be asked before we open it up to general comments and discussion. So I don't see any hands raised with specific questions about any of the slides or methods. So you should just unmute yourself and speak up if you have any. So Delegate Cullison.
Thank you, Commissioner. I just want to clarify, just in terms of the reinsurance piece, you know, separate and apart from all the other discussion. Am I understanding that if we did nothing now, if we did no changes in, and ARPA it expires, we still will have a fund balance of, I think it was $373 million in our reinsurance fund. Is that in 2028? And am I understanding that correctly?
Yes, that's the latest projection. And yes, and I mean, that's mainly driven by the ending fund balance of the first waiver. You know, as a reminder, we would be spending more than we're bringing in starting in 2026 when ARPA expires. It would, you know, be on a path towards draining that fund. But yes, we're starting off with a very healthy fund level. At the end of this first waiver, we're expected to maintain that fund level for the first 2 years while ARPA is in effect. And yeah, right now, you know, there's no big doubts that we would run out of money, but before the end of the waiver, but we would, you know, not have a plan for the following 5-year period at this point.
So, and do we have any sense of any kind of advance warning, or what the time period of advance warning we might get about the sustainability of ARPA?
I mean, I am personally pretty pessimistic that ARPA will get extended early. I believe it will be like what happened last summer, where the federal government puts it off till the end and is debating during the summer of 2025 whether to extend something. You know, but you know, I could be pleasantly surprised. But nothing I've been monitoring has indicated there's any discussion at all on the federal level about extending it at the moment. It's, you know, out of everybody's mind right now because they got last year's extension.
Yeah, I wish we had a crystal ball, but we don't. So,
So Brad, can I just point out two other things if I read it correctly? So those projections, they seem to assume that the young adult subsidy and any of the other subsidies stop at a certain point in time. So in that state outlay line, it's 0, 0, 0 after a certain point. So that is an assumption that some of those current subsidies that have sunset dates would actually sunset because they're not included in where you wind up within your balance.
Correct. That's a good point. Yeah, the young adult subsidy is not going out to 2028 in these projections. It's ending after 2026 as currently scheduled.
You know, so I think that one of the things as policymakers begin to look at some of those numbers is to think about what are existing uses of the subsidy money that you may feel are appropriate to continue at what level. And then also to the extent that we have talked about adjusting and looking at where there might be more bang for the buck in terms of keeping people insured with reducing some of their cost sharing arrangements. Those costs would have to be added in. So the modeling is become so matrix oriented that, you know, we are kind of moving our way incrementally along to sort of get an idea of where the policymakers, you know, both within the agencies and within the General Assembly are moving, so that as they converge in modeling, we're able to get more and more precise. But I did want to point out that that number doesn't include the continuation of some existing programs. Any other questions before we give folks the opportunity to comment or to sort of raise issues, concerns, or discussion? Or and again, I appreciate it's a lot and we need to come back to this and we need to provide more opportunity, but whether there are any preliminary thoughts with regard to, you know, directions where people might want to go. And I'm going to call on Matt in 1 second, but I will remind, you know, all of the attendees that if you desire to be heard, we are more than happy to bring you over. Just note that in the chat room and we'll bring you over so that we can hear what you have to say. So Matt Celentano, please.
Thank you, Commissioner Brain. Matt Celentano here today on behalf of the League of Life and Health Insurers of Maryland. And like you said, Commissioner Brain, it's sort of an overwhelming amount of information, and I'm sure that everybody is going to want to dig in. But I just want to reiterate that I think every single one of the carriers is in support of the reinsurance program. Nothing has changed there. And as you might remember, some of the carriers were opposed to the funding source in the last discussion, and we sort of remain opposed to that sort of scheme. But that being said, we want to explore all the possibilities that were laid out today to figure out what is the best fit for the program moving forward, because there's no doubt that it has been successful. We are a little concerned at the sort of framing it out as the possibility to increase the funding, because we believe, or increase the tax, because it would only make the challenge of affordability to small businesses even more challenging. So we would be opposed to raising the premium or the 1%. That being said, I think there are plenty of options on the table here that we could best fit the program to make sure that everybody has access to a quality, affordable plan, and we look forward to continuing the conversation. So that's all I wanted to say today. Thank you very much.
Thank you, Matt. I appreciate it. Other folks that have points they'd like to make or more detailed questions or comments? I can tell by the lack of hands up that people feel overwhelmed, and it's going to be important for us to have more opportunities after people have digested things. I saw Vinny first, so I'm going to call on him first, and then I think Ms. Clapper.
Thank you very much. A great presentation. I have to leave in a second, as you know, and Stephanie's going to be talking a lot more about this, but I just hope that, and I understand why in this study analysis, deep in-depth analysis was done of revenue sources that other states are doing. That made a lot of sense, but I would hope that for the final report, there's some discussion of potential other revenue sources that we've laid out, like raising the alcohol tax, the polluter pay tax that's been introduced with money going for healthcare, and the benefits of making high-cost drugs more affordable for everybody. So I hope that those will be part of the final report, and I hope we can discuss them at length at the next meeting. But thank you for all you're doing.
Thank you, Vinny. Thank you. Ms. Clapper and then Ms. Rivkin.
That is what I was going to say. I think Vinny broke up a little bit. So he had mentioned the alcohol tax and also a tax on carbon polluters. And so just want to echo that it would be great if we could consider putting those into the report.
Thank you. And Deb?
Hello, Commissioner. So we are still going through the numbers and we'll have to review them again based on the new analysis that since they're going to change slightly. And this is way above my pay grade with all those numbers. However, from an overarching point of view, I think from Care First, obviously we have always been strong supporters of the reinsurance program and want to see it thrive. We do think we have one of the best reinsurance programs in the country today. So we're comfortable with keeping at any parameters that will continue at the same levels we have now in terms of rate reductions. We have, I think it's around 30% rate reduction. We're certainly open to how that has to be done. If you all, in your wisdom, believe that we should be increasing attachment points, we do think it's important to keep the program at that current, 30% rate, and make sure that whatever is done, we can figure out a smooth transition. And I think I just wanted to highlight a little bit, and I think Brad did a fantastic job, and I think Delegate Cullison also raised this in one of her final statements, that we are running, I think it's around, if I did my math right, a $50 million deficit each year. If we pull out this money, if ARPA expires, and that really is not sustainable in the next phase of the waiver. So I think we really do have to think about, if we're going to do other types of subsidies, I think our position would be those subsidies should not be pulled from the reinsurance market, from the reinsurance money, because even the assumptions are true assumptions, and they've been wildly, they varied year after year of what we ended up getting. And so because of that volatility and because of the fact that we won't have any additional monies when for the next phase of the 5 years, if we move forward with reinsurance, which of course we hope we do, we would request that we consider using subsidies that are outside of the reinsurance program for any other types of subsidies, that they won't be drawn down from the reinsurance money.
Thank you for that.
Thank you.
Delegate Cullison? You're on mute.
Sorry, I was so brilliant too. In the context of discussion, I just hope that we will keep in mind as we do these kinds of models that there's some balance in some places with cost savings. And I think that's a concept that we often miss. And we need to put that into the calculation in some way. For example, my sincere belief is if we can cover more people, we decrease our liabilities, our financial liabilities, because They, you know, and I think I said this earlier, you give people preventive care, then you have less emergencies. And I think, you know, one of the experiences we're having right now, although it's, you know, it's really new, is when we passed the bill that provided dental care for adults in Medicaid. Within 5 months' time, 100,000 people had taken advantage of that, which means that's the level of need. And those 100,000 people are probably not now going to the emergency room, and they would have ultimately. So I think, you know, and my point is, let's you know, look at the big picture, not just in terms of how much things cost, but what some of the balance in savings is. Thanks.
Thank you. I think that's really well spoken. And, you know, particularly with respect to dental, the cost of standalone dental and information about standalone dental is frankly one of the primary questions that our folks get. And our folks do 500 or 600 on the ground interactions at various community centers and every place you can imagine. We had 80, for example, scheduled in September already. And talk and discussion about something like standalone dental insurance, where you wouldn't expect that. You know, it's a very common question because it's relatively inexpensive as a product. And if you can't afford anything else, right, that is something that oftentimes people will still buy for, especially their children and their teenagers. And that's a big preventative item. So any other thoughts or questions as of this point? Is there anyone who is among the attendees who would like to be brought over to comment? Okay, I have a question for you all going forward. So I think that this is so our intent was not to beget silence by overwhelming people with so much information that they would have brain freeze. Although my brain feels pretty frozen, and I've looked at these slides several times. So I completely understand that. Our goal is to make sure that we are sharing the process and the information that we're getting. We have some updates to make to our website, which we will do, all of the updated slides, but most importantly, the spreadsheets themselves, which have much more detail and will allow stakeholders, that includes companies and includes others, to be able to manipulate some of those numbers. And we also are extending through August 25th is the time frame for folks to provide any written thoughts or written comments. I think that what might be really constructive for the group would be, and this is my question for you, is we want to get together again after August 25th and have another opportunity for people to talk these concepts out? Or is it more fruitful for the working group to put out a sort of a draft and begin to bring some of these ideas together, and then have conversation around those ideas, which will be more targeted in terms of, you know, these are the impacts over time. This is the potential impact on the reinsurance fund, you know, on the use of the assessment monies, on enrollment, you know, et cetera. So I know that I just threw out a question to a bunch of people who are on mute, who might have difficulty expressing their points of view, but I would invite anyone who has a point of view about what they think the next logical step is for us to make sure that we get really good stakeholder feedback to let me know. And if you don't want to say that right now, you can put it in the chat, or you can, you know, send it to us offline. But I want to make sure that we get this part of it right in terms of input. So any first thoughts about that approach, which approach we want to go down? So I'm not saying, go ahead, Brad.
Yeah, Commissioner, I'll just say, you know, I was hoping to get some feedback on, you know, people's priorities. You know, I'm definitely hearing a lot of echoing that, the level of funding, not raising assessments is important, and concern about where these funds are being generated. But it would definitely be useful for me to get, different stakeholder perspectives on where they would prioritize, amongst these different options that we have presented. I think we've heard a little bit of that, but the more detail you can give about the priorities from your perspective, and if the top priority is keeping the assessment where it is, then what are your secondary priorities, and where do you think that money should be going? If your top priority is focusing on one of these programs, and you do think funding should be increased, let us know that too. I mean, that's the kind of feedback I was personally hoping to get as we work towards drafting up this paper.
Well, and I think that that's what we're all hoping for, but the silence that I'm hearing makes me concerned that what we've presented is so enormous and so frankly dispersed that it's hard for people to actually capture that and be able to say, do this, do this, do this, do this. And it might be more helpful for folks to be able to comment if we kind of brought some of those scenarios together. And I may be wrong about that. Tracy, did you want to say something? Tracy DeShields?
Yes, hi, everybody. Well, my thought would be, I think it is a lot of information and a lot to process. And I think if we can sort of have time to think about it and maybe come back and just have that discussion, I think then, Brad, you will hear more about priorities and where people think we should land. But I think, you have to also, and also taking into consideration the comment from Delegate Cullison about balancing, funding, because there's going to be some savings. Yes, there's going to be upfront costs. But I think all that taken together, I think it would behoove us to sort of think about it and then come back. And I think you can have like a real cogent discussion around priorities.
Tracy, is the information and the way we presented it, recognizing that some of the more detailed spreadsheet material will be there as well, the Excel, is this, do we need anything more, or is this enough for folks to be able to dig in and then come back with comments and ideas if we convene another meeting at the very end of August or right after Labor Day?
I think we have a lot of information, and I don't know, maybe somebody else can chime in here, but I'm thinking we have a lot of information. And I think with the information we have, I think we should be able to come up with decision points around priority. So I think the information we have is enough.
Ben, were you going to comment? Oh, I'm sorry. Delegate Cullison?
Thank you, Commissioner. I would agree with Tracy. I think it would be good to have another stab where folks come back just responding to the information that you gave us today, because I know that it's hard for me right now to say what I know, one priority of mine, which Brad, you have already articulated, but and I would ask that folks, if they have questions about the data, that they send it to Jamie, and perhaps the beginning, if we did another meeting to just discuss what we learned today, we could answer those questions at the beginning of the meeting and then delve into the discussion. I think that would be helpful. I think that would be helpful to you in terms of writing a report, because you would people would be able to be more clear about what they're thinking in terms of priorities, where they think there's some give and take, and how to make choices among all these different options.
That's well said. Ben?
Yeah, thanks a lot. Nice job, Brad. What I think, the next iteration, I think there should be some winnowing of the proposals. I think it is a lot, it's overwhelmed me today. And I think if a smaller group could maybe rank order, or maybe not group proposals that are more or less promising. I think, the basic health plan, it always seems like we feel like we have to do it, but it just doesn't work very well for us. And maybe that's one we cast off, although emotionally it is appealing. The other thing that I think Delegate Cullison raised, and this isn't really the main direction of all of this work, but what of the proposals do we think would be conducive to a further expansion in coverage, more of a take up? I think pulling things out by different dimensions. If we did this, this would potentially lead to a coverage expansion, or alternatively to help people understand kind of the old CBO winner loser tables, on some of these proposals, who's going to benefit. I think you did that to some degree in some of them, but maybe a little clearer across all populations would I think helps, in particular some of the people who don't have time to look at all of this data. But I really think it's an impressive amount of work. The challenge now is how do we winnow it down to look at what are the best, strongest proposals, giving, and I think, the carriers kind of laid out, their constraints today. If there are more, that's probably helpful, as well as, some of the points that Vinny raised, as well as something that we want to take into consideration, but maybe some proposals need to be cast off.
Well, thank you. I appreciate that. Any other thoughts or comments? So here's my proposal for, or I think we go from here. I think that I would invite everyone to, as we planned, submit your comments to Jamie Sexton. It's in the chat, but you can send them to any of us in the MIA if you forget, and we'll make sure that they get to Jamie and we'll make sure they get posted. To Delegate Cullison's point, also direct your questions. So if you have not just comments, but you have questions, something you don't understand, it doesn't make sense, what we will endeavor to do is answer them and post those answers on our website in advance of another meeting. So, if we can do that efficiently, that will give people the opportunity to have their questions answered before we go into another meeting. I'm going to confer with Brad and the interagency group about whether one additional item that we can put out is, to Ben Steffen's point, maybe provide a little bit of information around these are kind of the best options. These are more recommended options and how it works together, and see if we can get that out as well. And then invite stakeholders back for the discussion about this data right after Labor Day. So that's I think what's going to be our game plan going forward. Comments and questions by the 25th, and an effort by folks to provide some interim answers to questions and maybe just a little bit more input around viable options with a good chunk of time to really talk through things right after Labor Day. Delegate Cullison, did you have a comment?
No, Commissioner, just pressed a button unintentionally.
I just didn't want to miss anything. And I want to make sure that, the members of the General Assembly and the staffers that are here, to make sure, particularly if you have any comments that you want to make or any questions that you want to ask or any process that is more convenient for you, that you let us know. You can let us know now. You can let us know in the chat. or you can just reach out to Jamie. Yeah, we'll definitely look at what people's schedules are like. Stephanie is recommending the 6th, but we want to make sure that the work group members are able to be there, and I don't have everybody's schedule in front of me. So I promise you that it will be, we will get right to it. We're not going to delay any of this. And the work group is already working on elements of the report. So no grass is growing beneath their feet, as you can tell. Okay, so I'm gonna just give it one more second to see if there are any other questions or comments. Craig, can you just help me make sure I haven't left anybody out that wants to say something?
Yes, I'm not seeing anyone.
Okay, Matt, were you turning that on to wave goodbye or because you wanted to say something?
Just wanted to say thank you.
All right. Well, with that, my true thanks to all the members of the interagency work groups and particularly Brad, the work that you guys have done has really been literally overwhelming. We have a process and a procedure to go forward that makes sure that you are as heard as we can possibly have you heard on these issues. And we will get back to you quickly in terms of a date shortly after Labor Day, where we can reconvene. And once again, send Jamie any questions that you have and your written comments. And if you can do that by August 25th, it would be very much appreciated. All right. Well, with that, I will give you almost an hour of your life back. So thank you very much. Take care.